sir?
Just minute. Dr. Kamal, sir, I'm just giving a reverse count now.
Yeah.
5, 4, 3, 2, 1, 0. We are live now.
A very good evening to all. My name is Dr. Kamal. I head the medical affairs at Ajanta Pharma. And on behalf of Ajanta Pharma, I welcome all of the experts and all of the delegates for today's meeting on Besicor T virtual launch meeting. We have Dr. Narsingh Verma and Dr. Professor PC Manoria as moderator for today's evening. For cardiology perspective, we have Dr. A. Srinivas Kumar. From diabetologist perspective, Dr. Anuj Maheshwari, and from nephro perspective, we have Dr. Professor Padma Shri Kamlakar Tripathi. So again, I welcome all of the distinguished experts. So before taking the meeting ahead, I would request our Indian business head, Mr. Poras Vakil, to kindly formally welcome all of the experts and take a corporate presentation. Poras Vakil, sir, over to you, please.
Very good evening and a warm welcome to all the delegates and the esteemed faculty in the speaker's box. Thank you very much for joining us this evening on this important occasion for us, and we are honored to have the presence of all of you in this webinar today. We have very eminent specialists who are going to bring a scientific feast this evening, and I'm sure it will be a tremendous value add. Since we have many doctors who have been associated with us for many years, I'm sure you would like to know, where does Ajanta Pharma stand today? And on behalf of Ajanta Pharma, I will just take around 3 minutes or so to take you through where do we stand today. Sunny, can you help me?
Yeah, sir, I'm just allowing you access.
Okay, I'll do that. I'll share.
Yeah, I've just enabled access.
Is the screen visible?
Yes, sir. Please, can you do full screen now, sir?
Ajanta Pharma, as you all know, doctors, is an Indian multinational company. We are a specialty pharmaceutical company serving global healthcare needs with empathy, innovation, and technology over the last 50 years, where we've built trust and innovation. We are just celebrating our 50 years, and thank you very much on behalf of my team to be a part of patronizing this organization. We have a global presence in more than 30 countries the world over. India and US contribute to a big chunk, almost 50% of our turnover. Team Ajanta employs more than 7,000 employees, which are from 28 different nationalities. We have 7 state-of-the-art manufacturing facilities, out of which a few are the US FDA approved facilities, and various other approvals from the other government regulatory bodies. This is what distinguishes Ajanta Pharma from the various companies in India. It's the Advanced Research and Development Center with a complete value chain from formulation development to analytical development, regulatory affairs, and synthetic development. We engage more than 750 plus scientists with state-of-the-art facilities in this particular advanced R&D center that you can see out here in the picture. And it is because of this R&D that we are able to build innovation, which is our differentiator. In fact, Ajanta Pharma has launched more than 150 first-time in India products over the last 10 years. This is one of the highest by any organization. These are new products or new combinations for the first time in India. We have been pioneers in launching various innovative products. These are some of the innovative products that you have been familiar with, just to give you a glimpse of some of the products as such. We have a strong presence in select segments. In addition to cardiovascular diabetology, We are in ophthalmology, dermatology, and pain management. We also contribute our bit to the CSR initiatives. These are the last year's CSR initiatives. The 22 is getting updated, and we would show that in our next program. We've also played our role during the COVID period, where we got a recognition from the governor of Maharashtra. We've had various recognitions over the years, and the reason why I'm showing you this is because of the inspiration, the confidence that we've got from our doctors, and we look forward for the same. One of the most prestigious has been from the hands of the Honorable Prime Minister himself. We've been proud to be among the top companies across sectors, which has been recognized across the various studies which have been done. Our latest award has been in the month of October, the last October, when we got the Best Managed Company Award presented by Deloitte, which, as you know, is the world's largest consulting firm. They are known to recognize the top companies in the world in terms of best management practices. And Ajanta Pharma is the only pharmaceutical which was in the group of awardees across segments in India. We also got the award for the best employer in 2022. And these have been some of the awards that I'm talking of over the years. Thank you very much once again. And this is a very important moment for us with the launch of Besicor tea. And without taking further time, I would like to hand over the session back to Dr. Kamal. We commit ourselves to bring scientific sessions and look forward for your continuous association. Thank you very much. Dr. Kamal, to you.
Thank you, sir. Now I would request our marketing head, Mr. Sunny Jaiswal, to kindly formally launch the Besicor tea.
Yes, Dr. Kamal, sir. Thank you, sir. Over to you.
Thank you. So just giving brief of the agenda for today. So the meeting will be moderated by Dr. P.C. Manoria and Dr. Narsingh Verma. Dr. P.C. Manoria would be moderate the session for cardiologist perspective, and Dr. Narsingh Verma will be moderating it from diabetologist perspective. It will be followed by session by Dr. A. Srinivas Kumar on cardiologist perspective. Dr. Anuj Maheshwari will take the session on diabetologist perspective, which will be followed by Dr. Professor Kamlakar Tripathi from nephrologist perspective, which will be followed by panel discussion. So Dr. Professor P.C. Manoria is Director of Manoria Heart and Critical Care Hospital, Bhopal. So he was former professor and head of Department of Cardiology, GMC, Bhopal. Dr. Manoria has been awarded Lifetime Achievement Award during WCCPC in 2008 by Bharat Ratna Honorable Shri APJ Abdul Kalam, and along with many other awards have been given to Dr. Manoria. Professor Manoria has organized several national and international conferences over last 40 years. He has edited around 33 books and 70 publications and delivered more than 500 lectures also. Dr. Narsingh Verma has more than 230 original publications in peer-reviewed indexed journals, and he has been awarded with 14 international and 38 national awards in field of cardiovascular and metabolic structure research. Along with that, he holds many important positions among the different bodies, different scientific bodies of India and internationally. Dr. A. Srinivas Kumar is Chairman and Chief Cardiologist in Cardiovascular Sciences at Apollo Health City, Jubilee Hills, Hyderabad. He has been awarded for S.R. Rao Research Award for Best Thesis in MD General Medicine. He is founder editor of National Medical Journal Postgraduate Medical Clinics of Osmania. Along with that, Dr. A. Srinivas Kumar has been part of many big international and national studies and has publication in reputed international and national journals. Dr. Anuj Maheshwari is professor and head of medicine at Hind Institute of Medical Sciences, Lucknow. He is vice president of RSSDI, Governor, American College of Physicians, India chapter. Along with that, Dr. Maheshwari has around 75 papers presented in international and national flora and 54 publications on diabetes, hypertension, and complications in indexed journals. Dr. Maheshwari has been awarded with many national and international awards. Dr. Kamlakar Tripathi is a recipient of very reputed award, Padma Shri. So Dr. Tripathi is ex-professor and head of Department of Medicine, Division of Nephrology at IMS Banaras Hindu University, Varanasi. He has more than 300 publications under his head and international 200 and national 110 publications. He was ex-president of UP Diabetic Association. He is president of Indian Society of Wound Healing, Indian Society of Hypertension, Chronomedicine, and he has published many more research papers along with that. So with this, now I would request our moderator, Professor P.C. Manoria, to kindly kickstart the meeting. Professor P.C. Manoria, sir, please.
So, good evening, everybody. As all of you are aware, we have gathered here to discuss this new combo of bisoprolol and telmisartan. Change is the way of life. Everything in this universe changes, so also the practices for management of non-communicable diseases keeps on changing. And the first major change which we have witnessed during the last couple of years is we have drifted from the conventional sequential therapy or step care approach to combination therapy, whether it is treatment of hypertension, heart failure, diabetes, or CKD. Combination therapy is the rule. And the most advantage of combination therapy is that if you are given one pill, only 10% forgets to take the pill. If you are offered two pills, 20% forgets to take the pill. And if you are offered three pills, 40% forgets to take the pill. And therefore, for better adherence and compliance, combination therapy is the rule. And besides, this also leads to better control of blood pressure or other disease you are treating. And there are also lesser discontinuation and lesser side effects. The second change which we have witnessed during the last couple of years is that we are drifting from non-selective blockers to highly selective blockers. And the molecule in question is a telmisartan, which is a highly selective AT1 blocker, and bisoprolol, which is a highly selective beta blocker. And this is executed to sharpen the therapeutic effect with minimum or no side effects. And the third change which we have witnessed is currently, we try to bring molecules which have a favorable effect on the comorbidities associated with NCDs, because all NCDs, the treatment is usually lifelong, and in the long run, several comorbidities develop. For example, diabetes, COPD, PVD, CKD, and others. And the combination of bisoprolol and telmisartan, as we'll see during the course of the presentation, has a favorable effect on all these comorbidities. So with these remarks, I'll hand over the session to Dr. A. Srinivas Kumar to deliver on the cardiology perspective. Dr. Kumar, please.
Yeah, good evening, sir. Thank you, Dr. Manohar, sir. Are you able to see my slides and hear me?
Yes.
Yes,
Okay.
sir.
Yes, sir. Visible.
Okay. Thank you. Good evening, everybody. Congratulations to Ajanta for this new launch of an interesting molecule, which is very useful to patient or management. As already briefed by Dr. Manohar, sir, we always wanted to give combination therapy so as to have a better compliance and better outcomes to the patient. And today we are coming out with the bisoprolol plus telmisartan, which is again supposed to be the best of the both subgroups of this drugs. As you understand, blood pressure, the two important pathophysiological mechanisms are, one is the sympathetic nervous system, other is the angiotensin receptor blockade system. If you have a best of the two drugs, probably we'll have a superior outcome. That is the basis of starting to combine these drugs. With this brief intro, I will proceed further. Briefly, how to manage is basically tell you about hypertension and cardiovascular disease outcomes, and then probably how they benefit by treatment, and then what is the role of heart rate in the control of blood pressure, how higher heart rate will lead to more mortality and morbidity. Then come on to the drug proper, which has a combination of a bisoprolol, which controls the heart rate well along with blood pressure, and touch upon the telmisartan, some of its interesting aspects, advantages, and from cardiology perspective. As already told, my other colleagues will take you through the nephrology and endocrinology perspectives. One thing very important we should also be thanking such molecules is with specialties coming up, we all became more and more tubular in our approach, but such molecules we make and meet all the specialists together. We should be thankful to all of them, and thank you, Ajanta, for making this possible to come, all the senior stalwarts. It's my pleasure and honor to talk in front of all of them, and thank you again for the opportunity. Hypertension and CV disease, as we know, there's a strong association, and hypertension is a very common problem. And one thing very good about it is the clinical trials demonstrated that antihypertensive drug therapy reduces the risk of it. So then, but only thing is, we always become wiser and wiser. How much optimal blood pressure is the optimal? And the targets are becoming lower and lower because we come to know that the better control of blood pressure, the better will be the problems. Just to recapitulate how dangerous was hypertension before, these are all the three important world famous top leaders, which are Churchill, Roosevelt, and Stalin. All of them died because of cerebral strokes, which was produced and world was shaken because in those days, the molecules like this were not available and the blood pressure was not very well controlled. That is to highlight. So, but we all need to know that heart needs to work smarter, but not harder. That in the sense that we need to have optimal blood pressure and with a low heart rate, appropriate heart rate, I would say, so as to get the best outcomes. So high blood pressure, along with, is not only predictor of cardiovascular morbidity and mortality, but when it is increased, is associated with a faster heart rate, then it is a more problematic scenario. In the sense that when the blood pressure, high pressure is associated with higher heart rates, it has more higher problem getting into problems. So this is what, again, untreated hypertensive subjects, approximately the faster heart rates, again, have more trouble. The correlation between blood pressure and the heart rate is independent of patient's age again. Sometimes they used to think that elderly people could have low pressure, low heart rates and things like that. And younger people, as we know, have a higher heart rates. But even in them, then having a higher heart rates will lead to higher problems happening. So this is again to show that normotensives as well as treated hypertensive subjects, if the heart rates are low, the events occurring per year are much less. So even this applies to the same even in treated hypertensives. Even after treatment, if blood pressure values are high, that means patient has higher chances of getting into trouble. That is why we want not only the blood pressure to be controlled, we also want the heart rates to be well under control. Now we have to see how best is that's how heart rate is found to be as an independent risk factor. And the heart rate was more than 83, then compared to those patients with a heart rate of less than 62, the mortality rates were significantly different. That's what is shown in this. Then this is because in one of the Indian studies also showed that many of the Indian patients have high sympathetic activity, and leading to 62% of them had higher heart rates and higher sympathetic activity. In other words to say, the control of heart rate and control of high sympathetic nervous system overtone is important in our country. When you see how is this elevated heart rate is leading to problems, it leads to atherosclerosis and ischemia, and then increased and remodeling and a chronic heart failure. All these again happen when the heart is beating faster because of increased heart rate. If you see this increased heart rate leads to increased oxygen demand, again ischemia, which again leads to major cardiovascular events. Other hand, the vascular damage, if the again atherosclerosis, progression of atherosclerosis, plaque ruptures, again lead to major cardiovascular events. That's how both high blood pressure as well as higher heart rate lead to this cascade of ischemia and cardiovascular events. If you see how low we need to go, then we had a study in Invest with the 22,000 plus patients with a 2.7-year follow-up to show that if the heart rates were more than 100, definitely the adverse outcomes were very high. Then when you are trying to control the heart rates low, how low we should go? If you see, probably we aim to get into this 55 to 65 because that's where the mortality adverse outcomes are the least. If you go further down, then probably some slight increase could happen because of J curve, and also sometimes patient may not tolerate and develop more of a problem. So that's why we target heart rates somewhere in between 55 to 65. So that is the heart rate we want in these patients. It's an elevated heart rate when it was analyzed again. With each increase 10 beats per minute, then mortality increase was 14% and the total mortality increase by 20%. That's how it is very important, not only to control blood pressure, but also to control it appropriately with appropriate the blood pressure heart rate values which we mentioned. This again shows various quartiles of patients in which heart rates were controlled, blood pressures were uncontrolled, and heart rates and blood pressures both were controlled. And both were controlled, the risk of getting into trouble was the least. This is a landmark study of the LIFE study, which actually was done with the older molecule, the losartan intervention for endpoint reduction. But if the heart rates were more than 84 compared to those with less than 84, then there's a significant 55% greater risk of cardiovascular death and 79% all-cause mortality. This is quite high figures. That's how after this also we became wiser ever since 2010 that not only blood pressure control, but controlling with optimal heart rate, what we want is most important to decrease problems. If you see why is this heart rate so important when it is happening with hypertension, if the heart rate is fast, as we all understand, it leads to inadequate, insufficient diastolic relaxation and improper filling, and then probably coronary perfusion also gets affected. And the faster heart rates leads to, again, development of LV hypertrophy and further problems. If you see, when the heart rates are beating faster, then heart also needs more oxygen to fill itself. That is, oxygen demand increases. So there is a demand mismatch, supply mismatch, and myocardial ischemia develops, which again cascades the problems as highlighted. So this, I think all of us are very wiser now to know that heart rate is important along with the heart rate control is important along with blood pressure control. The increasing heart rate along with the overactivity of renin-angiotensin system together again contributes to the hypertension and CV comorbidities. If you see when hypertension sympathetic overactive, which happens in many Indian hypertensive patients. So along with it, we also know that two other important aspect is renin-angiotensin system, which again mutually reinforcing leads to regulation of blood pressure and controls and outcomes in the patients. So that's how we want a combination drug which can control the sympathetic nervous system as well as control the renin-angiotensin system, which is a combination of beta blocker and ARB. Then now we see which beta blocker and which receptor blocker. Now we have to choose the right beta blocker. We know some of the times older drugs which were again had spread some bad news about beta blocker, but the latest ones which are more cardioselective have effect on peripheral sympathetic nervous system causing reduction, and again cardiovascular sympathetic systems marked reduction happens compared to many other molecules which hardly have any effect on the sympathetic nervous system. That's why we have no other option but for taking beta blockers in controlling this sympathetic activation. Then how is this happening how the beta blockers were controlling is BP control is known, but they also known that new onset of heart failure and the regression of left ventricular hypertrophy happened with the usage of beta blocker. So heart rate with a less than 70 is desirable. That's what was mentioned in this landmark article. If you see beta blockers in hypertension, why did we not find the benefits before? That was with the combination of diuretics and the traditional beta blockers, which intrinsic differences had not lipophilic and did not have the advantage of sudden cardiac death, and more importantly, did not lower the central aortic pressure. That is why I think originally the atenolol-like drugs has spread the negative news. But if you see the newer beta blockers, which are the specific beta blocking agents, that is, which have a specific condition which of blocking only beta 1 selective receptors rather than combining both beta 1 and beta 2, which will have a negative effects. So that's how the negative things which are out of style, which was thought of before, now we became wiser that probably selective beta blocker, the newer beta blockers, which do not have the beta 2 side effect blocking, are better. These algorithms, various societies actually, though stepped care approach is not given up now, the combinations are straight away preferred. ACE inhibitors, ARBs, calcium channel blockers, or diuretics. But it also mentions consider beta blockers at any step when there is specific indications for their use. Example, heart failure, angina, post-MI, atrial fibrillation, and young woman with a planning pregnancy. So these are some of the things which we've come across in day-to-day practice. That's how it's very important not to neglect the role of beta blockers in control of hypertension in our country. Coming to this recommendations, class 1 indication, if you see, among antihypertensive drugs, ACE inhibitors, ARBs, beta blockers, calcium channel blockers, diuretics, all of them have demonstrated significant BP reductions and outcome reductions. That's class 1. Even in this, beta blocker is included. And the combination therapies are generally preferred, out of which, again, then we tend to combine beta blocker with calcium channel blocker or receptor blocker. This is, again, a class 1 recommendation. And the beta blockers, if at all you have to reduce the comorbidity and improve the comorbid outcomes like post-MI failure, heart failure, and all control of heart rate and angina, again, it is a class 1 indication. So don't think that it is given up totally. There in the class 1 indications, not only the control of hypertension, but also in combinations and also in prevention of the comorbid problems. So that is why it is very important to use these molecules. The other indications are all mentioned here, which you all know: symptomatic angina and heart failure, things like that, where beta blockers are still useful. Then this is a busy slide. For sake of time, I can't go into details, but suffice for us to know that there is beta 1 and beta 2 blockade. Beta 1 blockade is good. Beta 2 blockade, which non-specific, is not good. That's the broad message. And then some of these beta blockers also have the nitric oxide production and vasodilatory effects, like the newer beta blockers. That is predominantly the other important effect of these beta blockers. Apart from the controlling of sympathetic nervous outflow, they also have this vasodilatory effects and also nitric oxide donating effects, which have additional advantages. So this is suffice to say. And the molecule of today, the bisoprolol, when it is combined to the other molecules, though the other selective molecules also are there, the advantage of bisoprolol is supposed to be increasing beta 1 selectivity. It has much, much more beta 1 selectivity compared to beta 2. That's how I think the preferred molecule, which is thought to be combined, is bisoprolol. The metoprolol, and which was again there before, is next to that, and the atenolol, beta vexolol, we don't use that because of a lack of lipophilicity and other advantages. So if you see the beta blockers metabolism, again, if the one is only purely renal, again, in renal you can't use this, whereas bisoprolol has a combination of both hepatic and renal metabolism. That's how the balanced clearance helps us to use in both these types of conditions. Now that is about selecting the beta blocker, which is ideal, which we thought bisoprolol has the beta 1 selective action, and that's preferable. Now we go on to RAS blockade, how to do that, which is the blockade of choice. Let us see now in coming 3-4 minutes. The ARBs, as we all know, has evolved right from losartan, which is still very popular with physicians, nothing wrong with it, but it is a twice daily molecule. It doesn't have some of the advantages of latest molecule of telmisartan, which we'll be covering. Then next came the valsartan, then irbesartan, then came telmisartan. Then afterwards, there's two molecules, olmesartan and azilsartan came, but telmisartan still stood the test of time, and still the molecule of choice and the maximum used receptor blocker, because it has a plasma half-life of longest plasma half-life 24 hours. That means once daily drug is effective continuously, high receptor affinity, and then it other important action is the PPAR gamma activity, which actually also helps in insulin sensitizing and improves the sugar controls apart from the blood pressure control. That is a unique action of this telmisartan. If you see the number of patients who are studied, I think this molecule is the one which is maximum tested in 51,000 plus patients. And we have various trials which are listed. It on target, I would say, is a trial program, which I would briefly cover up. And if you see the endpoint outcomes, whichever you see here, any part of the risk factors to, again, MI developing stroke, remodeling, LV dysfunction, and end-stage problems, angiotensin plays a role in all this etiopathogenesis. And obviously, when that has a problem, on target showed that telmisartan, along with ramipril, telmisartan showed equally good effects, and combination was not good. That's what came out. That's how now we became wiser that combination of telmisartan and ramipril should not be given. On the other hand, telmisartan has all the benefits without the side effects of ramipril. This cardiovascular continuum after the on target is now complete, showing that telmisartan works right from the risk factor level to the MIs, LV dysfunction, and end-stage problems. Wherever you have a trial done, telmisartan came positive. If you see this, this slide shows again all the stages in coronary artery disease, peripheral artery disease, stroke, heart failure, everywhere telmisartan had data and showed benefit. That's how we now decided to combine bisoprolol from beta blocker and telmisartan, which has other advantages from the receptor blockers. Now, I'll briefly cover up in the last 3-4 minutes about the cardiology perspective, how this combination molecule is likely to help in heart failure before I hand over to my other specialty colleagues. So in India, we do see a lot of young patients. Young patients we come across, various software professionals, others who are 20 to 40 years of age group also develop hypertension. So that's how we do need to this molecule, which is controlling these molecules well without the side effects of beta blocker. This again, creative study showed that beta blocker, bisoprolol and metoprolol had equally good effects of control of heart rate and the blood pressure. And then this is in this telmisartan and carvedilol, this is anyway different type of combination, which is not right, I would feel. But anyway, showed that telmisartan was better than combining carvedilol in recurrence of atherosclerosis. Indian guidelines of hypertension, I would say, in younger patients still keep the beta blockers here, A, B, C, D. The older one, C, D is okay. The younger one still we have B kept here. And then each step, though it's not step care approach anymore, you have a combination of drug therapy. But again, we know that beta blockers are useful in younger individuals. If you see how many percentage of hypertensives in our country are young, many of them would agree that varies. Numbers could vary from 10 to 30%. And then if you see, ARBs and beta blockers are preferred drugs of choice in young hypertensions. And the heart rate control, how important it is. Again, many of them would agree that said in the survey that about 57% had opined that heart rate control is also important along with blood pressure control. So if you see how we are able to control this with in some of the studies which are shown, bisoprolol obviously when compared to atenolol showed better blood pressure control, which is seen here. And bisomet is another trial in which compared with metoprolol, again showed that bisoprolol had slightly better advantage compared to metoprolol. If you see this BRIGHT study, when starting from the baseline, with the control of the heart rate as well as blood pressure. We wanted both the heart rates and the blood pressures to decrease. And after 2 weeks of 3 months of therapy, there is 25 mm systolic blood pressure reduction, 14 mm diastolic blood pressure reduction, and heart rate control of 12, which is actually what is required in these hypertensive patients. If you see this, why these specific advantages were studied in the central aortic blood pressure monitoring study showed that bisoprolol was very effective in central aortic blood pressure reduction. That's how the positive benefits could happen. Then telmisartan, as we said, is a better sartan compared to all other sartans. which would see the green one here. The light green one is telmisartan, which had a maximum systolic blood pressure reduction and diastolic blood pressure reduction compared to all other sartans which are mentioned there. If you see, then combination of drugs, as we know, are more better, obviously. The telmisartan monotherapy and then telmisartan, the number of changes of blood pressure, then how much patients would respond. If you use multiple drugs, the combination of 3 drugs, probably the response would be much better. So that's how we use telmisartan in combination with these other molecules too. Then if you see telmisartan across, as I've shown this, the disease cardiovascular continuum, as I said, the risk only ARB with 24-hour control blood pressure reduction. That's how the risk of developing into trouble would be least when you use this molecule. And then you have also a lipid-friendly molecule as PPAR gamma activity, which is there. Again, reduces the triglycerides, increases insulin sensitivity. Again, sometimes noted that LDL cholesterol neutral and HDL could increase. So that is the advantage of using this molecule. So unique ARB with a PPAR gamma modulating activity. If you see the atherosclerosis, left ventricular hypertrophy, endothelial dysfunction improvement, inflammatory marker reduction, again is there with telmisartan, reduces the cardiovascular events. Post-MI, post-PTC also we have studies. Regression of left ventricular hypertrophy and decrease of left atrial fibrillation is also noted in the various studies which are mentioned here. And the on-target is a big trial program, I would say, which has shown all these benefits. And if you see about the studies about the beta blockers in heart failure, then CBs showed favorable results, 34% reduction. Merit heart failure, metoprolol was used in this heart failure patients. Copernicus, carvedilol, best is bucindolol. If you have to see all the drugs, bucindolol, which has some problems, had less of reduction, but both metoprolol, carvedilol, and bisoprolol all have decreased problems, risk reduction by about more than 30%. That's a great benefit which is happening. This CBS2 trial was selectively done with bisoprolol, showed again 34% reduction in all-cause mortality with bisoprolol compared to placebo. That is a very welcome change for all these patients. That's how other trials which are done with Copernicus, seniors, merit heart failure, all these drugs. If you have to see, just remember one thing as a broad thing. If your risk reduction, cardiovascular death reduction, sudden deaths would be something like 1/3, and the repeat hospitalization would be something like 20% reduction with the usage of beta blockers. That is a great advantage, and sudden cardiac deaths prevention would be much, much more. With this, I think I will stop here, and I request my endocrinology colleague to take through diabetes perspective. Then finally, we'll have nephro perspective. Then we can have some group discussion after the all 3 presentations. Thank you. Thank you again for your patient hearing.
Thank you, sir. Thank you for your wonderful presentation as always. Now, I would request Dr. Narsingh Verma to kindly moderate the session for diabetologist perspective, which will be taken by Dr. Anuj Maheshwari. Dr. Narsingh Verma, sir, over to you, please.
Thank you. Thank you. As we know that in most of Indian diabetic patients, it is very difficult to control hypertension, basically by single drug. So telmisartan is a good drug, and we are using it even twice a day, that is 40 milligram twice a day or 80 milligram once a day. But still, it is difficult most of the time to control hypertension. And when we talk about hypertension, I will agree to my previous speaker as well, that in Indian scenario, basically Southeast Asian scenario, the hypertension and diabetes both are 10 years earlier. So we are having more young patients, both diabetic and hypertensive. So in the very young patients, of course, the beta blockers can be a very good choice. And especially if the beta blockers are not having the side effects which are always thought with beta blockers, especially erectile dysfunction is one thing which I will talk about. And here it is almost seen that it is very less with this particular bisoprolol. And there are some findings which say that even it gets better by using bisoprolol. So in this particular thing, this particular beta blocker is different from the other beta blockers. So it is very exciting to see this combination of beta blocker plus the telmisartan, and a different beta blocker with telmisartan. And I will say that even in diabetic individuals, in a particular series of patients or group of patients, this combination can be a better alternative. Let us see what Professor Anuj Maheshwari says about this. I think Professor Anuj Maheshwari does not need a great introduction because he's known all over the India, across the world, because he's the governor of ACP India chapter. So with this, I invite Dr. Anuj Maheshwari for his deliberations. Dr. Maheshwari, please.
Thank you, Dr. Verma, for the kind introduction and kind setting the field. And thanks, Ajanta Pharma, for giving me this opportunity. Should I share my screen?
Yes, sir. Yes, sir.
Kamal, can I share my screen?
Yes, sir. Please, sir.
Yeah. Okay. So, as it has been already told, that now we shall be talking about the diabetologist perspective about this combination, telmisartan and bisoprolol. As far as the diabetes is concerned, everybody agrees on this point. Dr. Narsingh Verma has also highlighted, previous speaker has also highlighted that both these diseases are going on vis-a-vis. As far as complications are concerned, the same, risk factors are the same, and both the diseases are coming out of the similar soil that is called insulin resistance. And when we talk about these two diseases are together, the impact is not like 1 + 1, 2, but this impact is like 1 + 1, 3. So, for example, if we can look over the occurrence of microvascular complications, once diabetes and hypertension both are there, we can see that more than 70% people, those who are having the end-stage renal disease, they are having diabetes, hypertension both. As far as the increased risk of the retinopathy, both the diseases are progressing towards the similar level of the complication. If we talk about the heart diseases, 3 times likely to have the coronary heart disease if diabetes and hypertension are together, and 2 times likely to have the left ventricular hypertension, and 3 times likely to develop congestive heart failure if both diseases are occurring together. Peripheral vascular disease, we can see it here that diabetes is having a greater predilection for the peripheral vascular disease, but when both the diseases are together, diabetes and hypertension both are there, it increases the risk by 2 to 4 times. Means simply by its presence, diabetes increases the risk of peripheral vascular disease 2 to 4 times in a patient of hypertension. Increased risk in the proportion to severity of the blood pressure could be seen in the peripheral vascular disease. And obviously, very well known, multiple times have been proven, once diabetes and hypertension both are together, the risk of the stroke becomes double. So here we can see that two vicious twins in the form of the blood pressure and diabetes. Now question arises, the role of the beta blocker. Role of the beta blocker has always remained very much controversial whenever the diabetes is there with hypertension. Now it has come out, or it has been taken out of all the algorithm for the management of the hypertension, even those who are not having the diabetes. We have seen multiple data in addition to the data, those who were coming from LIFE and the atherosclerosis research in community, means ERIC study, that beta blockers actually increase the risk for the new onset diabetes by 25% and 28%. But that beta blocker, what we are talking today, that is the bisoprolol, is quite different from the other beta blockers. There are the evidences that higher doses of the bisoprolol may provide higher mortality benefits in patients with heart failure with reduced ejection fraction, as well as in a subset of the heart failure with reduced ejection fraction patients with type 2 diabetes. So bisoprolol actually does not cause significant change in the glycemic profile also in patients of type 2 diabetes as well as in systolic heart failure, which is usually expected from the other beta blockers. Now the question arises, why telmisartan? We all know about the benefits of the telmisartan. A good number of the trials has shown the appropriateness of the telmisartan in hypertension and diabetes. It is a molecule which is having an additional receptor agonism that is called as PPAR gamma receptor agonism. This not only works on the angiotensin 1 receptor, but also it works on the PPAR gamma receptor. So that's why it becomes like a molecule which induces the insulin sensitivity, which increases the insulin sensitivity, reducing the insulin resistance. At the same time, it has been seen to be inducing the PPAR gamma activity in angiotensin 1 receptor deficient cell models, independent of its angiotensin 1 receptor blocking action. What does it mean to say? That even if the patient is not getting the benefits of the angiotensin 1 receptor, PPAR gamma activity benefits will be there if the telmisartan is being used. So this PPAR gamma activity has been seen independent of the angiotensin 1 receptor, and what we could really realize it here that angiotensin 1 receptor is also working on the insulin sensitivity and insulin resistance reduction, but apart from this PPAR gamma activity, it is working. Means PPAR gamma activity is separate from this action of the telmisartan. Effects, it reduces the renin-angiotensin system's activity. PPAR gamma pathways are agonized because of what? Hypertension is controlled with reduction in the insulin resistance. And what we could see, the commonest indication and most important indication comes out for the telmisartan, that is the hypertension in metabolic syndrome. Once the blockade of the upregulation of VEGF messenger RNA is being done and de-stimulation of the reactive oxygen species or oxy-free radical in retinal pericytes is being done by telmisartan, this becomes the promising treatment strategy for the early treatment of diabetes with retinopathy. Complete blockage of the receptors leading to the advanced glycated end products protein expression in retinal endothelial cells, providing the novel beneficial effect on diabetic vascular complication. Let's talk about the telmisartan's activities, two activities together, which makes it actually the metabolic sartan. One is angiotensin 1 receptor antagonism, and another is the PPAR gamma agonism. And this antagonist and agonist activities together actually brings more and more closure towards the cardiovascular protection. Angiotensin 1 receptor antagonist activity reduces the blood pressure. Apart from that, it also has its impact on improvement of the impaired insulin signaling pathway, causing the improved insulin sensitivity by improvement of the glucose metabolism, and finally the metabolic syndrome is benefited. On the other hand, the PPAR gamma activation is taking care of the insulin sensitivity. From another side, at the same time, it also reverses the cholesterol transport and cholesterol absorption, leading to control of total cholesterol as well as LDL cholesterol. So telmisartan is a molecule from the two different ways. It keeps an eye on the cardiovascular protection and keeps control on the cardiovascular protection. So telmisartan has been tested, as I already said, by multiple trials in multiple set of the patient, but after jotarolimaz eluting stent implanted in patient with hypertension and diabetes together, what we could see the results were very encouraging. Actually, it reduced neointima volume. It reduced the atherosclerosis progression 10 mm proximal and distal to the stented segment. At the same time, we could see that brachial ankle pulse wave velocity, independent of blood pressure, could be reduced, and glucose and lipid control in hypertensive type 2 diabetes patient could be encouraged or improved simply by use of the telmisartan. So that's why we can say that telmisartan and bisoprolol combination could be a much more than simply a combination of the sartan and beta blocker. It is a very different set of the medications which could help the patients of the hypertension when they are being given together. Thank you. Now I would like to request the moderator to take us forward for the nephrologist perspective. Over to Dr. Narsingh Verma.
Thank you, Dr. Maheshwari, for giving this very important perspective regarding diabetes and this particular combination. And we all know that in diabetes, there are a lot of complications, and diabetes is known because of the complications. And cardiovascular and renal, these are the two important complications we usually have in the diabetic individuals. And when we are selecting the drug to these diabetic individuals, we must think about the cardiovascular and renal complications as well. So to take further knowing about the renal perspective, we have very eminent nephrologist within our panel, and he's none other than Professor Kamlakar Tripathi. So I will request him to talk more about this particular combination, whether this has a renal advantage in these subgroup of patients, or otherwise what is his take about this particular combination of telmisartan plus bisoprolol. So we'll like to know from Professor Kamlakar Tripathi, sir. Professor Kamlakar Tripathi's introduction has already been given. He is a well-known nephrologist of the country and known across the country, and had been awarded Padam Shri, and he is a very good orator. So welcome, Professor Kamlakar Tripathi, sir.
Thank you very much. Let me share my slide before we start. Now, do you get my slide on the screen?
No, sir, not yet. We are still waiting.
Not yet.
Yeah, we are still waiting, sir.
Just waiting into the slide right now. Just wait for a moment. I should be through quickly.
Tripathi, sir, would you like me
You got
to?
it? You
No,
got
sir.
it?
No, I
Not
think
yet?
still not yet.
Okay, let me try again. No.
Sir, if you allow, Sunny can share that.
Okay. Go ahead. You give to him, and then probably I'll be able to better do it.
You can share the slide.
I'm just starting sharing the screen, sir. Just allow me a second. Just allow me. Sure, sir. Yeah.
Yes.
Tripathi, sir, over to you, sir. Please go ahead, sir.
Okay, let me see if I got it. Just wait for a moment.
We have given
Tripathi, sir,
Yes.
I'm sharing the screen for you.
It has come. So
Okay,
good evening. Thank you, Dr. Verma, for setting the. I'm not still getting my slide.
Sir, should I share the screen on your behalf? Is it fine?
I think that you can do that.
Yeah,
Yeah,
sir.
that's I wanted you to do that. If you can
Okay,
do it.
fine, sir. I'm just sharing my screen again. Just allow me a second.
Okay.
Fine, sir. Over to you, sir. Please go ahead, sir.
Yeah, got it now. The story of hypertension, as Dr. Verma said, rightly starts from the nephrologist. Otherwise, this primarily was with the physiologist for a long, long time. Till we got the Guyton kidney 1, Guyton this kidney 2, different 2 models. And then afterward, we learned about the exaggerated natriuresis. It took a long time to understand how kidney regulates the blood pressure. Blood pressure starts anywhere, but it is primarily a sort of homeostasis between the raised blood pressure, normal blood pressure, and for the 2 reasons that afferent arterial pressure is 35 millimeter mercury, efferent arterial pressure is 25 millimeter mercury, hydrostatic pressure is 10 millimeter mercury. So we are left only with 5 to 10 millimeter mercury as effective filtration gradient to make a drop of urine, and which we require 1.5 liter. We have to make urine to get rid of the uremic toxins. And therefore, the major burden on the regulation of the blood pressure through intraglomerular modulation comes from the kidney. So next slide, please. Can I have the next slide? It takes little time to get the next slide. Yeah. The renal plasma flow, as I said in the beginning, is an important component, and it is not synonymous with renal blood flow. These are the 2 different things. So ultimately, it is the plasma flow which is responsible, and once you have an increased intraglomerular hypertension, then the resistance becomes more, and we have a sartans and we have a ramipril. Ramipril is a very old drug. All ACE inhibitors are old, but sartan stands little better in reduction and improving the renal plasma flow and in reducing the renal resistance. Next slide. Hence, once you use and you get improvement in the intraglomerular normotension from the hypertension before systemic hypertension manifests, then it leads to reduction in the albuminuria. This is the principle. All antihypertensive medicine, whether you start from the calcium channel blocker, you start the ACE inhibitor, you start the beta blocker, you start the potent antihypertensive property would also reduce the albuminuria for the very 2 reasons that they also reset intraglomerular. But it is always better with the sartans than the ramipril. And there are answers, or physiological answers for it, because of the specific 81 and 82 receptor mediated action. We have 81, we have 82, we have 83, we have 84, up to 87. But important physiological function is monitored through the 81. And 82 has got benefit. Using telmisartan reduces albuminuria better than the ramipril. Next. Now look at the microalbuminuria. Microalbuminuria is a forerunner of many conditions. It's forerunner of the congestive heart failure. It's a forerunner of the hypertension. It's a forerunner of the deteriorating the renal condition. It's a forerunner of the vascular endothelial health. So when you look at the microalbuminuria at the initial value and then followed by the 3-month and 12-month, there have been significant reduction in the albuminuria when you use telmisartan. Now today we do albumin creatine excretion ratio. That's more important. And there are papers which still suggest now, after 2012 and 13 publication, they suggest that sartans also better handle the albuminuria and the albumin creatine excretion ratio. This is better. It's less than 300 milligram. That's the ideal. When you increase more than 300 milligram in 24 hours, that's detrimental. And also the ratio should not exceed more than 300. Next. Next slide. So this is what have been studied, and this I'll take up this slide later on in the discussion. But what have been found out with the telmisartan on renal function with chronic kidney disease, that it reduces proteinuria up to 19%. It improves on serum creatine up to 18%, and also it improves on the GFR up to 24.7%. This CKD means it could be stage 2, stage 3, stage 4 to some extent. But there have been papers, and I'll come in the later part of the discussion, that now we have the Stop ACE ARB trial, which is started in 2016. And this trial showed what would happen if you continue ACE and ARB beyond certain EGFR. I'll conclude at the later part of the slide. But in initial part, as long as we will stage 3, you can safely use statins and they would improve EGFR, means they would bring back you from stage 3 to stage 4. They can also reduce the creatinine value, which was more than 50% reduction, and they also improve on the proteinuria. Next. This is called TRENDY study. This is telmisartan versus ramipril in renal endothelial dysfunction. I said you in the beginning that the AT2 receptor has certain advantages. AT1 receptor also have certain built-in advantages. And one of the disadvantages would be the proliferation of the endothelial cell. If they proliferate more, the lumen is narrowed, then they have more damage, and there is more additions, molecules starting ACM, VCAM, and these addition molecules could enhance atherosclerotic process. So TRENDY study have shown that telmisartan works better in long-term treatment and improves endothelial function in hypertensive patient. In type 2 diabetic patient, type 2 diabetic patient, why is it used? Because these patients have already microangiopathy right from the 7 to 6 years before they develop dysglycemia clinically. So if you want to protect, and that's where the initial captopril study by Mogensen group started. They picked up the patient of the type 2 diabetes when the EGFR was super normal, grade 1, and they also picked up at the grade 2. And they had hypothesis what? That endothelial dysfunction starts earlier in deterioration in diabetic patient. So it is better to use a molecule which would protect the endothelial function. And thereby, when you use, they also improve on the adiponectin and decrease the blood pressure. So telmisartan would increase the nitric oxide activity and would support the preservation of cardiovascular function. So what is doing? It's working on the endothelial dysfunction. It's improving on the adhesion molecule. It's improving on adiponectin, decreasing the blood pressure, and thereby providing a good intraglomerular endothelial filtration process, which would preserve in long term the heart as well as what we call now cardiorenal syndrome. Next. I said in the beginning, now we do urinary albumin creatinine ratio. This is more scientific because as your GFR decreases, as your age advances, after 60 years, you decrease 10% of functioning nephron every decade of life. Accordingly, also, the albumin excretion is affected. So it is better to now monitor urinary albumin creatinine ratio, which is evidence on the ARB treatment, increase in plasma BNP and greater decrease in ARCR than non-ARB treatments. Hence, it improves on albumin creatinine ratio with ARB than the non-ARB group. If you look at the values in the plasma BNP, which is one of the indicator of the heart failure and the cardiac myocyte health, would give insight into the significance of BNP and UACR as predictors of cardiovascular and renal risk on antihypertensive treatment. Next. This is the bisoprolol shows we have another molecule, very good beta blocker, highly selective beta blocker like carvedilol and bisoprolol. Have been using these three molecules, nebivolol, carvedilol, bisoprolol. Metoprolol is older one, atenolol is the oldest one. Atenolol gradually is off the practice, but there are still some physicians who continue to use it. What this study has shown that because of the less diazability, bisoprolol, those patients who are on maintenance dialysis program. Now, a lot of patients on maintenance dialysis program because government is supporting. In UP, almost every district is now being supported with good dialysis programs. So these patients on long-term dialysis, atenolol they have been using before. It's a dialyzable, therefore they get resurgence of the hypertension immediately when you dialyze these patients. So you have to be very ready when they walk out of the dialysis unit, they can get the exacerbation of the acceleration of the hypertension. So bisoprolol is one which has got least desirability than in comparison to atenolol and metoprolol. Carvedilol is still much lesser, but what is important is AV difference method between the two, arteriovenous circulation. When you hook the patient to the dialysis machine, it's better preserved. It's 96 plus minus 17 when we are using bisoprolol. So when you use this patient, one of the important part, and that was the long-term old story, you want a good perfusion. You want a good flow from the arteriovenous fistula, or for that purpose, when you are using shunt. If you do not have good perfusion to the dialysis machine, effective filtration would go down and there would be recurrent hypotension and it would not be very effective dialysis. So it is better to choose a molecule which would sustain and would not produce exacerbation of the hypertension at the end of the dialysis. Next slide. So it has superior safety with combination. Next. This study was conducted in China and which have shown the combination of the both with beta blocker versus no beta blocker in relation to the chronic pulmonary disease exacerbation, COPD, and also look at the all cause of mortality. And when you look at the on my left side, right side on the presentation, then there is increased superiority of the most of the SART versus non-beta blocker, selective versus non-selective, and the selective beta blocker have certainly advantages because they do not produce, which was initially problem with the initial presentation, initial molecules. They would not produce bronchospasm. Number one, they would not deteriorate congestive heart failure. Very old traditional beta blocker method like propranolol has a propensity for the heart failure, so they divide of that, they also help in the reducing the cardiovascular hospital mortality as well as all cause of mortality. And the wonderful part is the heart failure. So selective beta blocker, highly selective beta blocker favors, it improves on the heart rate, means decrease the heart rate as we have talked before. It reduces all cause of mortality and it also have a COPD protection. It doesn't increase exacerbation. Only when you look at the third from the top, this is 0.98. That one have shown beta blocker versus no beta blocker with the non-selective. Rest all selective have shown advantageous effect. Next slide. This is the beta-1 selectivity results in minimal effect on airways resistance. The same extrapolated in asthmatic patient. Not that was in the COPD patient. This is asthmatic patient who are at a time maybe worse. COPD, they tolerate better. Acute asthma deteriorates. When you use atenolol, then there is change in the airway resistance, very high. But when you use bisoprolol, 10 milligram, 20 milligram, 10 milligram bisoprolol does not increase the airway resistance as good as placebo, and therefore it does not deteriorate asthmatic patient who are hypertensive. So you can use these freely rather than non-selective beta blockers. Next slide. Do beta blocker cause depression? Traditional older beta blocker, yes, certainly. They have been used in anxiety. They decrease the heart rate because these patients used to have a severe tachycardia, severe changes into the neurohormonal transmitters. So there was debate whether beta blocker, they cause depression or not. Highly selective beta blocker like bisoprolol do not produce hypertension as some of the older, I said propranolol, which used to produce adverse effect and also one of the cause of the depression. Next slide. Next, looking at the two sides of the coin. No, please go back to the previous one. Looking at the two sides of the coin, there are, can you go to the previous one? You changed it quickly. Can you go to the previous one? previous one. Yeah. This is the first systematic review and meta-analysis investigation of the 50. Please hold on. You change it so quickly. Hold on.
Sir, am I on the right side, sir? Can you please guide me?
Go back. Go back. One slide back.
Okay, sir. Fine. I'll just go back, sir. This is the one, sir, you're talking?
No, this is already there. Yeah. No. Then next. Next.
This one, sir?
Ahead.
This one?
Next.
This one, sir?
All right. You one slide you quickly. Doesn't matter. So
Okay, fine.
the beta blocker and sexual dysfunction, and this was the true with traditional older beta blocker, non-selective beta blocker. There was erectile dysfunction, there was failure of ejaculation, there was loss of libido, all three. But when you use bisoprolol, then in comparison to the placebo, there has been almost no change. Carbidolol 13.5, propanolol 5, atenolol 3. Carbidolol though has been very good, but then it has got much severe effect on the sexual dysfunction, whereas bisoprolol is 0 as compared to. Next slide. What? So with combination and the safety profile, this is safe in diabetic hypertensive patient, safe in COPD. These to what extent we'll discuss later on, and also safe in sexual dysfunction. Next slide. I think we have come to the last part of the present slide, last few slides. So to summarize, bisoprolol gives 19.6-fold higher affinity to beta-1 receptor. Telmisartan is strong binding AT1 receptor, I said, due to delta lock structure. Dosing convenient is once a day, both. Is the pharmacokinetic parameters more than 90% oral absorption, high availability, 50% renal, 50% hepatic clearance. This is the reason I was talking to you in the beginning, because as long as you have 50% functioning nephron preserve, this drug would be doing whether bisoprolol would not produce any associated effect and will tolerate well in COPD as well as asthmatic patient. Minimal effect on glucose and cholesterol level, and 98% elimination through the fecal route of the telmisartan. Therefore, it does not deteriorate pre-existing renal function. And proteinuria, it potentiates PPR gamma favorable effect on lipid. Next slide. One or two slides more. So this is the hexagon which have been seen again and again. You have a choice to combine beta blocker with calcium channel blocker. You have a choice to combine with MRAs. You have to choice to combine AZ-ARB or ARNI. You have choice to combine with SGLT2 and thiazide chlorothiazide indapamide. Therefore, depending upon what sort of patient you are taking, younger patient, high adrenergic drive over, these patients would require a beta blocker is a must. Elderly patient, very high systolic upsurge would require calcium channel blocker. Patient who have got early part and proteinuria, early part of the CKD would be better on ARB-AC. Patient who have got propensity for the heart failure, RD would be better combination as SGLT2. SGLT2 is one can free to use and make a combination. Now, the most popular combination would be using a highly selective beta blocker for younger patient with, if we have a propensity for the heart failure, then with RD. SGLT2 inhibitor is preserved for diabetic patient. However, there are non-diabetic patients where also this has been used, and there are indications that it does a lot of better to the cardiac myocyte as well as the kidney. Next slide. So thank you very much. Life begins with the first heartbeat, ends with the last one. So better to preserve our heartbeat till our last breath. Thank you. You can go
Thank
now
you,
for
sir.
the discussion.
Thank you, sir. Thank you for very exciting and very interesting presentation. And as you said that in those conditions where we want to give beta blockers and we were afraid of the side effects, this combination can be a very good choice because it has all the good one of sartans and also the good one from the beta blockers. So I think this will serve as a very good combination in a variety of our patients in the coming times. Thank you, sir. Thank you very much.
So, sir, I request all the moderators and the experts for panel discussion, please.
There's some chat questions which have come. I think that also can be answered.
Yeah, in
Yeah,
the
yes.
chat questions are there.
Yes. There was one question. How is this combination good for young hypertensive patients? See, this is from the Dr. Nayak. All the time we have been telling right from the Dr. Manoria's presentation and then followed by the Dr. Srinivas Kumar, younger patient, high adrenergic type, resting tachycardia, these are the patients who require, and telmisartan has more cardiovascular protective, endothelial cell protective, as well as renal protective action. So this would be a good combination in the younger patient. I think Dr. Manoria can also further.
I think bisoprolol, particularly in young hypertensive patient, if your heart rate is faster, the basal heart rate, this is likely to produce a desired response. And many times we have seen young hypertensive who are always busy IT professionals. Even if you give small doses of beta blockers, the blood pressure comes down. And bisoprolol has the unique advantage that erectile dysfunction is minimal, as you have told. So if you are using bisoprolol in young, you have to pay special attention on the quality of life, because our hypertensive patient not only live, they should also feel well. So that is a choice for the young hypertensives. Other beta blockers have the problem of erectile dysfunction besides other effects.
Sir, another question here is which beta blocker will be drug of choice in young heart failure patients?
See, we have 3 beta blockers which are approved for treatment of heart failure, as was shown by Dr. Shri Kumar. Now, how do we select which patient we should use, which carvedilol, and which bisoprolol? Now, if your patient of heart failure has comparatively lower blood pressure, around 90 or 95, and there are features of postural hypotension, if you want to use beta blocker, the choice will fall on bisoprolol and not carvedilol, because bisoprolol, the reduction in blood pressure is much less compared to carvedilol. If the patient is on carvedilol, in such a patient, we shift this patient from carvedilol to bisoprolol. If your blood pressure is very high, you may opt for carvedilol because that drug will also affect the beta function as well as the blood pressure. If a patient of acute myocardial infarction has arrhythmias, beta blockers like this also has anti-arrhythmic action, but the problem with bisoprolol, it is not available in injective formulation. With AMI, where we are using beta blockers for tachyarrhythmia, we always prefer a blocker which has an injectable formulation also. So metoprolol is the usually choice because it's also available in injectable form. Otherwise, you use metoprolol now because injectable therapy because of sudden VT. It will be problematic to use metoprolol on top of bisoprolol. So under that circumstances, we prefer metoprolol. And for those patients where the longevity is life, depending on the severity of heart failure, if other things are not there, we will always prefer bisoprolol because it produces a favorable effect on most of the comorbidities, COPD, which is not uncommon, diabetes, which is not uncommon. And so that is how we select. Otherwise, all 3 beta blockers are approved by all guidelines across the globe.
Regarding
one question on the CKD.
Yeah,
one
CKD.
question on the bisoprolol recommendation in CKD patient, Dr. Patil. I said in the beginning that the beta blocker, especially the bisoprolol, would be an acceptable choice in CKD patient. And what happens when we fail, we cannot continue. And in those patients who have got the GFR less than 30 or 15 and who are on the dialysis, then probably ARB's high dose cannot be given. So bisoprolol alone would be a better drug in these patients because it is not dialyzable as other beta blockers are dialyzable, and it has a better control on the heart rate. Some of these patients who have got a lot of arrhythmia, a lot of problem with the propensity towards the tachyarrhythmia. So you can still go ahead with bisoprolol in CKD patient, and for the non-dialyzability, it's a renal safe. It also works onto the different arterial. It is a better option to go with the CKD patient with the bisoprolol, provided these patients do not have a hyperkalemia, provided these patients do not have a bradyarrhythmia. These are the two only indications where you have to reduce the dose of bisoprolol. In a fixed dose combination, you cannot do that. But these are the two situations in which you can go ahead with the bisoprolol.
Dr. Tripathi, one issue which is projected by some of the nephrologists during a discussion on similar combination is that in severe CKD, because metoprolol only 5% is excreted to the kidneys, bisoprolol 50% is excreted to the kidneys, whereas bisoprolol, the dialysability is less compared to metoprolol. So you will opt for a less dialysable beta blocker, or you'll ask for a beta blocker which has a least excretion to the kidneys. So
I said in the beginning, yeah, if patient is on maintenance hemodialysis, and some of these patients, because of the volume depletion, post-dialysis, they develop certain hypotension. So we would there look for the molecule which is less dialyzable. If molecule is highly dialyzable, these patients would get exacerbation of hypertension. Very severe. The moment you close the dialysis, you return the fluid, you return the saline, these patients get exacerbation. There bisoprolol would be a better choice. Metoprolol, I agree, because of the problems related to the renal perfusion. Metoprolol can be used, and it has been used equally safely, but these patients would get a reversal of the hypertension. If you use bisoprolol, chances of getting exacerbation hypertension post-dialysis patient is less. But those patients who are not on dialysis, stage 2, stage 3 of the CKD, even stage 4 CKD who are not on the dialysis, you can still continue with metoprolol.
Dr. Anuj Maheshwari, one thing, what is the mechanism which beta blockers produce diabetes, particularly the non-selective ones? What is the exact mechanism?
Thank you, sir. Obviously, the beta blockers are supposed to be causing hyperglycemia most of the time, especially non-selective, and few of them are the selective also. They may be having certain predilection towards development of the hyperglycemia. So that is the reason because of what we usually avoid the beta blockers in type 2 diabetes patient. And we see that this things very commonly occurs in our patient, and mostly we find the mechanism which is more commonly seen in our patient.
What happened?
Internet is gone, I think.
Yeah, it's the insulin resistance, Dr. Manoria.
Hello?
Beta blocker, the traditional beta blocker, they produce little insulin resistance, and they also decrease the perception of the hypoglycemic event. That was the reason why beta blockers were not being used initial part of the diabetes patient who had a coronary artery or pain, the angina, these patients we were not using. But that older traditional non-selective beta blocker produces the insulin, thereby they deteriorate the dysglycemia.
Other mechanisms are glucagon production is increased by few, and then glycogen conversion to glucose is increased by few. So that's how the overall multiple mechanisms lead to hyperglycemia. The older ones, traditional, which have beta 2 stimulation, not the selective, which have beta 1.
Dr. Narsingh Verma, any effect on the blood pressure variability, any study of this combination on the BP variability?
Sir, BP variability because of the telmisartan, very long-acting drug, so it reduces blood pressure variability. And regarding this particular beta blocker, it is again in comparison to metoprolol, it is long acting. So I think in blood pressure variability, this combination will be better in regard to other combinations.
Sorry, sir, just I got disconnected because of the internet problem.
Yes.
So I was willing to complete my sentence, which could not be done. That beta blockers, what we already using in our day-to-day practice, many of the times they impairs the insulin secretion from the beta cells of the pancreas. And because of what, and this remains the difference in various beta blockers. And those who are non-selective, they are having the more such kind of the property, and those who are selective, they are having less that kind of a property. And this property is least in the carvedilol.
Hello.
Dr. Kamal.
Hello.
Yeah.
Yes,
Yeah, yes, sir. Yes, sir. But I was worrying whether I'm listening or not. Yes, sir. It's going fine. Yes, sir.
I think we have
Some
answered
other-
most of the question.
Yes, sir.
On the
Yes,
chat
sir.
box, we have answered most of the question. Dr. Manoria, any question left?
Yes, sir. I think last question on role of telmisartan in AFib patients.
In?
AFib, atrial fibrillation patients, sir.
Oh, Dr. Manoria's area.
ACARB has been shown to decrease the recurrence of atrial fibrillation, and then it will also regress left ventricular hypertrophy, and it may also have a favorable effect on the diastolic dysfunction. So it benefits atrial fibrillation patients.
Oh, sir. Sir, I think this question was answered previously also. The Dr. Shripad has asked question, sir, how can you say that this combination has no sexual side effect? Please elaborate.
Recently introduced guidelines of RSSDI for the hypertension management. They have also mentioned that telmisartan is the best agent if we are coming across with the hypertension with the atrial fibrillation to manage with. So this is already recommended by the RSSDI.
Hello.
Are you listening me, whatever I am speaking?
Yes, sir.
Yes, yes, we are listening, Dr. Maheshwari.
Yes, sir.
Okay.
We are listening, Maheshwari.
So, sir, any additional comment on the last question on no sexual side effect with this combination? So this was discussed previously. Any additional comment from any expert?
It's a very complicated issue. Yeah.
But most
It
of the
is a
young patients are very
complicated
scared
issue.
of this.
Yes, yes, yes.
Prescribed
See, lot of endothelial dysfunction, the moment patient complains of erectile dysfunction, endothelial dysfunction already has set in at the microangiopathy level. So it's a very individual perception. Very many people on very high dose of atenolol do not feel it. Many people on even a smaller dose of traditional beta blocker, they get sexual dysfunction, erectile dysfunction, failure to ejaculation. Therefore, I think it varies. The mechanisms are plenty. There are many. It's based on the vasodilatory effect. It's based on the beta blocker receptor. It is also based on the alpha blocker. Even most potent alpha blocker can also lead to sexual dysfunction, erectile dysfunction. So chronic hypertensive patients are at the bed, but any medicine can, it's a lot of individual variation, and therefore one has to go for the causative factor rather than only aiming at the sexual dysfunction.
Sure.
It could be sometimes very bad if you do not answer it.
Sure, sir.
I think we can close now, 9 o'clock.
Yeah, thank you. Thanks a lot, sir. I would just request our cluster head, cardiac cluster head, Mr. N. Srinivas, to give a vote of thanks, please.
Yeah, thank you very much, Dr. Kamal. Sir, on behalf of Ajanta Pharma, I am N. Srinivas, working as Associate Vice President. Take this opportunity to express my sincere gratitude to all the doctors present at with Besicor virtual launch meet. I especially thank Padma Shri Dr. K.K. Tripathi, Dr. P.C. Manoria, Dr. S. Srinivas Kumar, Dr. Narsingh Verma, Dr. Anuj Maheshwari for sharing their vast experience and in-depth knowledge with all of us. Sir, your deliberation will surely guide many of their medical practitioners, and your presence, active participation, all of you has implemented the success of this Besicor virtual launch meeting. I am sure two eminent, one best beta blocker in class, and second one is the best used ARB in the class, that is telmisartan. I am sure Besicor will definitely aid you in your quality treatment, translating into quality patient care as well. The stocks are readily available, sir, now at all the chemists nearby you. Your utmost prescriptions are very, very valuable to us and kindly contribute and motivate us to the great extent. Once again, thank all of you and the speakers by name from the bottom of my heart, and thankful to one and all for making this event very successful. Thank you so much, Doctor. Your knowledge indeed enriches and
Good night, everybody.
Good night. Thank you.
Thank you so much, sir.
Thank you.
Thank you, sir. Thanks a lot,
Thank
sir.
you so much, sir.
Thank you so much, Dr. Manoria, Dr.
Yes.
Narsingh Verma,